Mic check, 1 2 1 2. Can you hear me?
I sure can.
All right.
Just sent him the invite again. Hmm. Let's see. I'm going to try and send it once more.
Hey, everybody, it's Dr. King-Mullins, also known as Dr. Tushy Touch Up, and we have a special edition of The Love Below for you. This month is Pride Month, and so we are all about making sure everyone has equitable access to care. So joining us shortly will be our pelvic floor physical therapist extraordinaire from Atlanta, Georgia, Lance Frank. So we're just getting them in momentarily, so thanks so much. All right. So we hope everybody is staying warm. No, actually, nope. Lord have mercy. I said that backwards. Hope everybody is staying cool in this warm weather. Hey, Lance in your pants. Hey, how are
Hey,
you?
There he is.
hey. Took a
Sorry, I had to
second.
do it. I had to do it. No problem.
Took a second for the request to come through. How are you guys?
Doing well. How are you?
I'm doing well. Sorry, I'm trying to get my camera set up here.
No worries. We
Um,
know how tech goes in this day and age.
right.
All right,
Anyways,
everybody. Yeah, so
um,
welcome everybody who's on live. For those who are just tuning in, I'm Dr. Erin King-Mullins, Dr. Tushy Touch Up, double board certified colorectal and general surgeon in Metro Atlanta. And this evening, we have a special conversation of the Love Below, our series, and it is Pride Month, and we are speaking with Lance Frank, a pelvic floor physical therapist. And so this is just a definitely an important conversation tonight. So, we're all about making sure everyone receives equitable care. So, Lance, tell us all about you and what you do and where you are.
yeah. I am a pelvic physical therapist, as you mentioned. I'm based here in Atlanta in Midtown. Um, and I am openly queer, I'm openly gay, treat as a queer pelvic PT. And that's kind of one of the pillars that I created my practice on, just my identity as a man and also my identity as a gay man. And so I treat all types of pelvic floor dysfunction, urinary issues, bowel issues, a lot of pain issues. But my target audience are you typically people with penises or queer people, kind of all of the LGBTQIA umbrella.
Okay, awesome. Well, thanks so much for that, and thanks for the care you provide. And everyone gets so woo, shaking in their boots when we talk about things that are other and that are different. And so, what I love about this conversation, my being a Black woman, which is pretty rare in the colorectal space, I naturally will tend to see a lot of Black women, right? Because there's certain the studies have shown that when you identify with your healthcare provider, you tend to feel more seen and you tend to have better outcomes. And there's just a better relationship sometimes, right? They have better outcomes. And so, definitely important to make sure we, continue having those conversations. So, we're going to dive into, so we got Sonia that's moderating for us in the background. She's going to keep an eye for any questions that come through the comments. But we're going to kick off with just some questions that we had in general so we can open our audience's eyes to the world of pelvic floor therapy in a different way. We actually spoke with Jennifer McGowan, who actually originally introduced you and I a
Love
while
her.
back. Yeah,
Yeah.
um, so, but a lot of people tend to center pelvic floor physical therapy and pelvic floor health around number one, women, right? And natural to some degree, the changes that happen after birthing children, but we all have pelvises. We all
Yep.
have pelvic organs, and
Yep.
pelvic organs are used for various things: bowel function, bladder function, sexual function, and reproduction, right? And so everybody's got some degree of all of that.
Yep.
So let's talk a little bit about, some of the spaces where pelvic floor health and physical therapy overlap with the colorectal space. What type of patients do we share?
I mean, I work with a lot of patients that have chronic fissures or chronic issues with hemorrhoids or painful bowel movements or chronic constipation. Also, being gay, I work with a lot of queer, not even queer patients. I work with a lot of people that are trying to engage in receptive anal penetration, and sometimes it's painful, or they have issues with tearing, or they have issues with fissures, or they have issues just like with pain during sex. And this is a hill that I will die on as a gay man, that bottoming or receptive anal penetration, there might be a little bit of discomfort, especially if it's not something that you're used to, but it should not be painful. And so if it is, a lot of times it's a muscular problem that's kind of getting in the way, and that's where pelvic PT can come in handy. And also, as a colorectal doc, I'm sure that I refer patients to colorectal docs for sometimes Botox to the anal sphincters if the pelvic floor muscles are just need a little assistance with kind of the work that we do in pelvic PT. So there's a lot of overlap in the colorectal department of with what we do as pelvic PTs. And I think having a pelvic or a colorectal doc to collaborate with just helps with the patient outcome through the entire experience.
Yeah, definitely, definitely. And we talk about that, like again, people will tend to just shut down when we start talking about, anal intercourse or intimacy. And, and there are a lot of heterosexual couples that participate in anal intercourse, married couples, like I see them. And one of the other things that people don't really touch upon a lot, and we have it in our textbooks, and I think it applies to anyone when we're talking about pelvic floor health. um, Studies have shown that about 25 to 30% of patients with pelvic floor pain or pelvic floor dysfunction have experienced some sort of sexual trauma in their lives in their past. And so, tell me a little bit about like how you incorporate that into your care of your patients. Is that something, we have to make sure we have trauma informed providers that are taking care of our patients, no matter what they look like. So tell me a little bit about how some of those conversations play out with you in your specialty.
Yeah, I mean, that is a tough one. Honestly, I work with a lot of patients that have a lot of I work with a lot of patients that have a history of some degree of trauma. And whether it's sexual trauma or physical trauma or emotional trauma, as a pelvic PT, you can't not talk about pelvic floor dysfunction and past trauma and how they interact with one another, because it's common. And in terms of, from a sexual dysfunction standpoint, I work with patients, and I kind of want to back up a little bit. Like when patients come in to see me and they have pelvic floor dysfunction, oftentimes there is a pelvic exam, but being staying in like the trauma informed realm, I try to make sure that I build rapport with patients. I try to make sure that I'm asking all the appropriate questions. I even open in my like intake in my conversation, I ask, whenever in part of the medical history, and like a lot of times pelvic floor dysfunction can be a function or a side effect of some sort of trauma. And I usually leave it open ended of, I say some sort of trauma, like of an emotional trauma, a physical trauma, sexual trauma. Is there any sort of history that you feel comfortable sharing with me? And sometimes patients are open to talking about it right off the bat, and sometimes it takes, a session or two, or they'll wait till the end of the session and be like, you asked about trauma. Once I've built that connection with them, they'll
Yeah.
ask about trauma, or they'll bring it back up. They'll say, "Oh, I did have this thing happen to me, or that I did have this experience." Or sometimes it doesn't come out until like the second, third, or fourth visit, but. Um, it is something that I try to sprinkle in, of like that introductory conversation of, you know, this, as unfortunate as it is common, and it's something that together we can help, I can help you kind of navigate through this. But I let people kind of move at their own pace. I never
Yeah.
force anything. And I never, if somebody is very clearly like either mentally shutting down, physically, visibly shutting down, like I'm not going to force a pelvic exam on somebody if they have some sort of history, even if they've told me that, if they haven't told me that they do.
Yeah.
And so I try to always operate from a trauma informed lens. And in the queer community, it's actually pretty common for people to have some degree of trauma. And I always try to lead with understanding and compassion, and
Yeah.
it's just a part of how I treat.
Yeah. And I think, the key is, and what we find sometimes with patients, like, even if they never divulge some of the things that they're dealing with, there's a certain level of change in that rapport when they know that you recognize that there may be something there. So even if they never share what it is, they feel seen. They feel like, okay, this person like understands that this is just not me, whatever, like making assumptions, or, being, stereotyping me, judging me, or anything like that. Like they're truly informed. They're addressing, patients, women or whatever. It's so funny, when we just talk about like women with incontinence. One of the things that I ask about so many things about their sexual history, their bladder function, and they never think, they know I'm a colorectal surgeon, and they're like, why am I asking about all this? Or, that they'll ask, I'll ask them like, tell me about your birthing history. How many babies did you have? How big were they? Did you have a long labor? Was there trauma? Was there force? And they're, especially the older women, they're like, man, that was 40 something years ago. And I was like, all of that plays a role. So let's talk about you and your life and everything like that. And let's see how that impacts what your quality of life is, kind of today. Um, so before we move on, well, actually, no, let's move on just a little bit more before we start taking questions, because we want to kind of continue to build this groundswell and this background of this conversation that we're talking about. So for anyone who's just joined us, Dr. King-Mullins, Dr. Tushy Touch Up here, speaking with Lance Frank. I can't talk today. Lance Frank, pelvic floor physical therapist, special edition this month, for Pride Month. So let's talk a little bit about, well, we actually just talked a little bit about kind of affirming care and kind of what that looks like, in your space. Um, Tell us a little bit about how pelvic floor therapy can specifically improve some of the dysfunctions patients may have as it pertains to anal rectal pain, fissures, hemorrhoids, urinary dysfunction, kind of bowel dysfunction, because people always think and they associate pelvic floor therapy with, Kegels. I say, oh, I'm going to send you to a pelvic floor therapist. Oh, I looked up online. I know how to do Kegels. No,
No,
that's not
no,
what it is.
yeah,
So let's just talk about that.
yeah. That's a pretty common misconception. A lot of people think, pelvic PT, like, are you just going to teach me how to do Kegels? And it's so far from that of what we do with patients, and it really does depend on the diagnosis. But since this is a colorectal conversation, I'll kind of focus mostly on colorectal
Yeah,
conditions. A lot of the patients that I work with, given a lot of, now at this stage of my career and the development of my business, most of my patients have penises and or are gay or queer, like I mentioned earlier, and so most of the patients that I work with have what's called an overactive pelvic floor. I know you know this, but for people who don't, it's an overactive pelvic floor is a group of the pelvic floor muscle groups. Just they're always turned on, they're always squeezing, they're always clenching, and they just really don't ever relax. And so when that happens, they lose their basic capacity to perform their job. So peeing, pooping, having sex all become problematic. for pooping, peeing, and penetration, those muscles are really just supposed to open and relax and get out of the way so that something can come in or come out. And in a lot of my patients with this overactive pelvic floor, I'm using this as an example because we can imagine the anal sphincter here. If patients are kind of stuck like this, it makes it really difficult to either get stool out or get urine out or to allow something to come in. And so a lot of what I do as a pelvic PT is I teach people, I help facilitate people learning how to relax their pelvic floor. And sometimes that can look like just breath work. Sometimes it can look like exercises or stretches, or, and sometimes it can include hands on work, whether that's external myofascial release work or internal myofascial release work, depending on the patient that's in front of me and what they're okay with and their degree of comfortability with me kind of working on their bodies. It can kind of look like a smattering of different things of kind of what pelvic PT looks like and how we help people. But as a just overarching statement, a lot of what I do, I always say this is my elevator pitch. I teach people how to relax their pelvic floors, essentially. If I had to whittle it down to one sentence, that's kind of what I do as a pelvic PT. Whenever
Yeah,
people have the mobility and have the flexibility to relax their pelvic floor, a lot of these basic functions of peeing, pooping, and having sex become a lot less problematic.
definitely, definitely. And it's so funny, just people don't really consider like the pelvic floor, like the musculature that's there, like the actual function and the collaboration that has to happen for you to appropriately evacuate whatever it is, bladder, bowel, or anything. And so, like one of the kind of analogies I use is just like, people, a massage therapist, right? You know how they're always like, "Ooh, you're super tight right there. Like you got this knot, we got to get out." And so when you're
Yeah.
talking about myofascial release or just kind of those types of things, the different type of physical therapy that may be required after any type of muscular injury or dysfunction. Our pelvic floor therapists are specifically trained to work on that area. And there's, so much quality of life that gets impacted by that. And, I often, you know, um, equate that, to women. Because again, I have OBs that I work with that are like, man, they wish that every single woman who's ever been pregnant and had a baby could get pelvic floor therapy. Because when you just think of what happens to just carry a baby, like the pelvis literally shifts and opens, so the muscles move with it. Most times it never completely goes back. So your anatomy completely gets changed, and you have to learn, just like if you got a hip replacement or anything else and you got to get physical therapy afterwards, same type of trauma. And so we're super excited to be talking tonight with Lance Frank, pelvic floor physical therapist, special edition for Pride Month tonight. So I'm going to actually just take a quick pause because we were just kind of going through some of the basics of pelvic floor physical therapy and what it's for and how it works. I just want to buzz Sonia to see if any questions specifically have come through for either of us.
Yeah, I think a really good one actually that says, can you both talk a little bit about where your work overlaps when it comes to, like you talked about, bowel dysfunction or anal pain? Maybe it's fissures or hemorrhoids. In other words, like it says, what do you each see that makes you say, this person needs both of us?
Got it. So
You want to go
I'll
first?
start. Yeah,
Yeah,
I'll
you go
start.
first.
So, classic story, someone comes to me and they're like, I'm constipated. And then I'm like, well, what do you mean by constipated? Are you not going? Like, do you not getting the urge to have a bowel movement, or you can't evacuate? And then we start talking and they're like, no, I can't get it out. Like I'm sitting and I'm pushing, I'm pushing, I'm pushing, and it's just not coming out, or coming out in little pieces, or whatever comes out. I still don't feel, like I'm clean. So then I start asking about the other questions about, bladder dysfunction, any incontinence or anything with that. And so I then have to go through a series of diagnostic tests to kind of understand where that dysfunction might be. So it may be an ultrasound that we get of the pelvis. One of my favorite tests is actually an MRI. It's called an MRI defecography. which is what we call as a dynamic MRI. And so a little bit of contrast goes into the rectum, and then the patient is asked to push, squeeze, cough, simulate having a bowel movement and all of those things. So we see what the different components of the pelvis are doing during times of activity. Is the rectum pushing down? Do they have a rectocele, a cystocele? Is the muscle just not relaxing at all? And so I'm looking for any structural things that I can repair, but also functional things that they're asking you to squeeze and it's just not quite happening. And I'm like, aha, I got a scene of my friend. So Lance, tell us a little bit about your side of things.
Yeah. So if that patient comes in who, says, I'm constipated, I sit on the toilet and I can't get things out, I'm push and push and push. Typically, going back to that, what I was talking about earlier about that overactive pelvic floor, I'm, as you know, the dysynergic defecation, a lot of patients will contract. Like I said, when earlier, the muscles are supposed to open and relax and get out of the way, essentially. And so a lot of what I do in those patients is just a lot of neuromuscular re-education, retraining your brain to talk to those muscles and instead of contract them, teach them how to relax them. And a lot of times that can look like internal work, or that can look like sometimes we'll do in the clinic. I've done balloon training with patients where we go through, we insert, this is going to might freak people out, but sometimes we'll insert a tiny little balloon into the rectum, inflate it a little bit, and then I'll actually have them practice expelling the balloon to try to retrain what a pelvic floor relaxation, or what I call a pelvic drop, should feel like, to allow something to come out without the muscles freaking out and clamping down around it. Um, so that's where therapy can really come into play, because I see people, I can't speak for you, but I would imagine as a physician, you're not seeing patients, once a week for twice a week for consecutive weeks at a time. Like, as
Right.
a therapist, I get that time to spend with patients. I spend an hour with every patient. And sometimes I see them once a week, sometimes I see them twice a week. It really just depends on the severity of their symptoms and how quickly they're trying to progress. But um, I have that time to spend with patients and help retrain their brain and retrain their muscles. And it's it's a pretty cool job to help somebody
Yeah.
regain that kind of quality of life. It's one thing to help somebody like fix their shoulder pain, but help somebody be able to go to the bathroom without, pain, or without reflaring a hemorrhoid or a fissure, is pretty cool.
Yeah. And it's kind of like sometimes it's chicken or egg, when someone can't evacuate, those muscles aren't relaxing, they're pushing, 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 and then they blow out a hemorrhoid or they get a fissure. Um, or vice versa, something happens, they just had one episode of constipation, they push and strain, get a really bad hemorrhoid, and now the pain is so bad down there, they're just reflexively clenching every time they have a bowel movement because it's too painful. So it can be one or the other thing that leads to another. But when I feel someone that's super tight down there, um, I like to engage pelvic floor physical therapy if I can, especially if it's chronic. Sometimes if it's a short-term spasm, there are some suppositories, some medicated suppositories that I can prescribe for folks to use. But, if I find something structural down there that I need to fix and those pelvic muscles aren't functioning appropriately, we oftentimes have to sometimes sandwich it. I have you start pelvic floor physical therapy so you understand what you're supposed to do. That way, whatever surgery I do to repair things down there, your body is not pushing and straining so much. You've been trained about what you're supposed to do so you don't disrupt that repair. And then you go back to pelvic floor physical therapy now that your anatomy has been fixed and shifted to kind of complete that whole process. So we're sometimes tag teaming these things, to make sure. And to Lance's point, um, I mean, for lack of a better term, not that I don't love y'all, but I'm a surgeon. I gotta cut it.
Yeah.
I'm trying to piece things together. And so when I'm telling you that I can't help you, I'm not meaning in the sense that, sometimes my helping you is sending you to Lance, like, and telling you that, because hey, I make my money by operating. So if I'm telling you you don't need surgery, I'm literally taking money out of my own, food out of my kids' mouth. So I'm not gaslighting you, just put it that way.
Right.
Um, Sonia, any other questions that have come through so far?
Yes, I was just scrolling. um, it says, Dr. King-Mullins, this is for you. Um, I saw something on your website about a procedure you do that seems cosmetic, but also seems like it's a functional reward, I guess is what they're trying to say. Can
Okay.
you tell me a little more about that and how would someone, I guess, the way they're writing it, kind of like identify if they're a candidate? I'm assuming they're talking about your Tushy Touch Up procedure.
Sure, sure. Well, thanks for reaching out. Yeah, so Tushy Touch Up is a name that I coined, focused on kind of anal restoration. While at face value, it may seem like it's cosmetic, but because at first glance, you might see large hemorrhoids or fissures or things like that down there or scars. But again, based upon the nature of that area and the trauma that is implied that happened for those things to happen, there's a functional restoration that happens with it. And so, if someone has large hemorrhoids that are obstructing the passage of their waste, or if someone's had prior hemorrhoid surgery and they have scars, things didn't heal well, and so now things are really tight and they need a scar revision. Um, Again, a woman who's birthed a child, and if they had a major scar or a tear, or if they had a rectocele or something like that. So the Tushy Touch Up is kind of like I call the real mommy makeover, but it's for anyone. So anyone who's had any type of trauma to that area that has either caused aesthetic or functional changes. We kind of talk about what your symptoms are. I examine you, see what things look like, and then we kind of come up with a tailored plan to kind of restore what your goals are. So it could include Botox to relax the sphincter um, for discharging waste. But again, removing hemorrhoids, tags, removing excess skin, revising scars, fixing prior tears or injuries. And so that's what Tushy Touch Up is. So um any how do you like, what do people ask you, Lance? Like, as far as like, because I know you're dealing with a lot of kind of the internal kind of beneath the surface work. Do you find that some of these things kind of impede you being able to fully treat someone, like, prior scars from surgery, or, hemorrhoids, especially if they're large and you're trying to, push for someone to encourage someone to push to appropriately evacuate?
Yeah, I do. I have a lot of patients that they'll have they'll have a hemorrhoid, or they'll have a fissure, and they'll have some degree of pain with that, and so that inherently causes this like pain reflex where anytime I'm down there, they're inherently wanting to clench or tighten, and I'm trying to have them relax and lengthen and drop their pelvic floor down. And so sometimes we're kind of fighting against one another. And um, I also have patients who they might have a hemorrhoid, or they might have a fissure, and they're like, I don't like, my hemorrhoids flared up again, like I don't really feel like I want to do internal work today because it's a little sore, it's a little painful, like are there other things that we can do? And of course there are, but it does kind of I don't want to say get in the way, but sometimes it does
Yeah.
impede my ability to be able to help them whenever they do have these active issues kind of in the way. On the flip side, sometimes I get patients who have seen a physician and have had a hemorrhoid banding, or they've had a hemorrhoid removed, and the hemorrhoid has been resolved, but the discomfort that they felt from the hemorrhoid removal has then led to pelvic floor dysfunction and this tightening and difficulties evacuating. And so sometimes I get patients before they have a procedure, and sometimes I get them after. It really just kind of depends where they're at in their journey. Um, but yeah, even the patients that I work with who've had a procedure already and I get them after, sometimes they're all, again, that pain reflex. They're just so tight and fear avoidant that anything going down there, they're like, I just had a banding removed, or banding, a hemorrhoid removed a month ago. Like, no, you're not going in there, you know?
Yeah. Yeah.
So sometimes it's on the other end, but there are times where it does impede my ability to help them to like my full capacity.
Yeah. And that's what I've learned, just kind of over the years in practice, like so first and foremost, everybody has hemorrhoid tissue, okay? It's a natural part of our anatomy. And so something happens, they get enlarged, inflamed, and they may have symptoms from it. But, one of the biggest things is, as they say, as we when we go through medical school, they always tell us listen to the patient. They will tell you what the problem is. And so, when I have a patient that comes to see me for rectal pain or anal pain, you know, I don't just look and say, "Oh, you got a hemorrhoid. Let's take that off." I'm like, "No, no, no." I was like, "I need," or they're like, "Oh, they sent you pictures of a colonoscopy. Can't you just?" No, 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 I can't. I need to see you. But also, let's specifically talk about the character of your pain. Is it pressure, burning, throbbing, spasming, cutting? Does it happen at the time of the urge to have a bowel movement, or does it happen at the time of you passing the bowel movement, or does it happen afterwards? And does having a bowel movement make it feel better or worse? So really defining that again helps elucidate, what the true problem is, because I can tell pretty much 90% of the time how we describe exactly when and how. I can tell them more than likely it's a fissure. Yes, I may look down there and see hemorrhoids, but the fissure is causing your pain. So let's treat that, because if I cut your hemorrhoids off and don't address the fissure, you're gonna be mad because I haven't touched anything that you said hurts and I actually made you hurt more.
Yeah.
Um, so I think that's very, very key in like listening to what the patient's symptoms are. Now, like I'll tell them, I'm not gonna gaslight you. If you want the hemorrhoids gone just because you want them gone, like that's fine. But if you want me to fix XYZ problem, I need to develop that problem to understand how I'm going to actually fix that. And so, I think, so how do you, we won't go down that road. Any, any follow up on that?
I, I don't think so.
Okay.
I look at conditions obviously completely different than how you look at them, but it's
Yeah.
kind of the same thing. By the end of their intake, I feel like I have a pretty good idea of what's driving their symptoms. And a lot of times I know, or I feel confident that I know whether or not it's a pelvic floor issue, or if it's something that I might need to send back to a physician to have another look, or if they haven't seen if it's some, I mean, as a cash pay clinician, I don't take insurance, I'm out of pocket. And so sometimes I get patients that haven't partnered with a physician yet, and I'm the first person they're seeing for their symptoms because they Googled their symptoms, and I'm the first person that pops up. And so
I need to get on your
sometimes
SEO.
sometimes I get patients that haven't spoken to anyone, haven't had any sort of imaging, and there are times where I'm like, I can treat you, but I feel like you need an MRI. You might need some sort of other set of eyes that aren't a physical therapist that have other tools to be able to treat you. And so, um, I forgot the point that I was trying to make with that, but it's nice to have to
No
partner
worries.
with with a colorectal doc just for another set of eyes.
Yeah. Definitely, definitely. Um, so let's see. Let's just go through a couple of and not that you have to get up and do it, but when we talk about everybody thinks that pelvic floor therapy or Kegel exercises or whatever. So let's talk about some core things for the patients with urinary symptoms. Let's start with urinary incontinence. What should patients, but they're trying to buy their time because the urologist is booking out for 2 and 3 months. What are some things that they can help with controlling their urinary symptoms?
Well, it really just kind of depends on what the driving factor of their urinary symptoms are. If it's somebody who is postpartum and they've just given birth, and their issue with incontinence is literally because of laxity, and as you said earlier, their muscles and their bones have separated, and they're trying to kind of go back to some resemblance of normal. Sometimes it's just a matter of strengthening those muscles and working on core control and pressure management so that they're not bearing down whenever they roll out of bed, or whether they're not standing whenever they stand up from the chair, they're not just like putting all that pressure onto the top of their bladder, and then that's when they leak. So in that type of patient, we do actually do a lot of strengthening based work, a lot of glute strength and hip strength and pelvic floor strength and core strength to work on regaining strength in those muscles. But if it's somebody who is an avid CrossFitter or a weightlifter or a runner, and they have a pelvic floor that is tightly clenched or overactive, their muscles function. I always use the analogy of a trampoline or a spring. Our muscles should be pliable. They should be able to have the flexibility to stretch and then recoil. And that recoil, if you drop an egg on a trampoline, it's going to absorb that weight and the egg's probably not going to crack. But if you drop an egg on the concrete, the egg's going to splat everywhere. And that analogy is exactly what happens with the bladder and incontinence. And so it depends on how patients show up to the clinic and kind of what their history is. But if somebody has that tightly clenched, overactive pelvic floor, we work a lot on down training. We work a lot on pressure management and actually learning how to relax the pelvic floor so the pelvic floor can absorb all of that pressure with laughing, coughing, sneezing, running, jumping. All of that pressure comes from up here in the diaphragm and gets pushed directly on top of the pelvic floor. And so the pelvic floor should have the recoil capacity to be able to stretch and then rebound to support the urethra so people aren't leaking. And so with urinary incontinence specifically, it really depends on are they what's considered an underactive pelvic floor or an overactive pelvic floor. And depending on these are very watered down like example or like kind of
Sure.
definitions, hallmarks, but on if they need strengthening or if they need more flexibility and relaxation, that really is going to dictate the treatment path that we take for them.
All right. So for the diaphragm, so you're telling me after my two C-sections, I need to hold my breath when I stand up? I'm just kidding.
No,
I'm just kidding.
no, no.
Just kidding. But somebody's out there thinking something like that. And so, we got to make sure like you don't try this at home, folks.
Yeah.
Um, so let's do the other side. Someone's having a little bit of fecal incontinence. Now I know, and actually I have a webinar coming up on July 29th, talking about incontinence. I can't remember what website. Anyway, you can go to my website and figure it out. But um, so let's talk about like fecal incontinence, right? Like I know it's multifactorial. It could be nerve injury, muscle injury, and stuff like that. But maybe some of the basics that, again, besides Kegels, like someone again is waiting to kind of get in. Besides making sure that the bowels are not too loose, and making sure that you're eating the right things. What are some kind of basic hallmarks or principles that folks can try to start doing to see if they can improve that quality of life?
Oh gosh, that's a loaded one.
Yeah.
With fecal incontinence, I always start with just the basic, and what I think is basic, but kind of what you mentioned. What is your diet like? Are you getting enough fiber? Is the stool is it just runny? Is it liquidy? Is it solid? Is there anything of substance that the anal sphincters can hold back? I usually start with that. And then if that can be modified, if they have celiac or if they have Crohn's or if they have a gluten intolerance, like all of that can impact their ability to take in food and the stool formation. But if assuming their diet's in check and they have a somewhat solid stool from a purely muscular standpoint, a lot of it comes down to, do you have an urge? Do you know whether or not you have stool in there?
Yep.
If you have an urge, can you control those muscles to be able to make it to the bathroom? Is it you go from sitting into standing and then the act of moving causes that incontinence? Does it happen when you run? Does it happen when you weight lift? Or could you just be laying in bed and stool comes out? Those sort of muscular components to how the stool is leaked, it dictates how I treat them. And honestly, a lot of times with that specific subset of patients, it really does come down to pressure management, learning how to like properly engage your core and properly engage your pelvic floor. So assuming people don't have any sort of nerve damage or they haven't gone through, I've worked with patients who they've had a prostatectomy or they've had prostate cancer, they've had radiation, and that radiation has completely fried just all of their pelvic floor muscles. And so
Yep.
they've developed fecal incontinence as a byproduct of their prostate cancer.
Hmm.
And so if patients have radiated tissue, a lot of times that muscle tissue is really difficult to strengthen after that. Like the muscle fibers themselves have essentially been fried. And so
Yep.
it's those are difficult, those are difficult patients to try to rehab. And so for those, we talk about I'll talk a lot about lifestyle management or aids to help while we're working on kind of this bulking up the stool and working on the tissue that is viable to strengthen. While we're working on that, there are also other things that we can incorporate. Actually, a rep just reached out to me a couple weeks ago, and I get through social media, I get so many like pelvic health sphere related products like thrown at me. People wanting me to promote their devices, and this is not me promoting this device, but he did come to my office and drop it off and talked about these new their rectal or anal silicone plugs that can be inserted to help with fecal incontinence. And as a PT who helps with kind of people regain their quality of life, I was like, it is the first FDA product like that on the market. And I was like, wow, this is actually a product that I could kind of support. Like I would actually recommend to patients.
Now, why
Um,
haven't they called me? I'm like, what the?
well, I
I
did
don't
give them their information. I
know.
did give you, like, they were asking for colorectal docs in the
Oh.
area, and that I talked to, and I was like, well, you should reach out to this one. I'm actually doing a live Instagram live with her later. um, but they're actually, it's a really cool product. But anyways, as a pelvic
Got it.
PT, I mean, we do work for those patients. We do work on pelvic floor strength, and it is a lot more than just Kegels. Like I'm not just having people lay on the
Right.
table and just like squeezing their pelvic floor. There's so much more to it. Like, can you engage your pelvic floor while doing other exercises or other functional activities? Um, but yeah, fecal incontinence is
Yeah. It's a
there's
crazy.
multifaceted.
And yeah, and so by the time people get to me, and I'm sure probably to you, they're kind of at their wits' end. They've seen so many different doctors and specialists and stuff like that, and people so underestimate the value of a good diet or nutrition plan, because typically, especially, well, there's a variety of different reasons. We have to figure out the cause of it, but it's easy for me as a physician or even you as a pelvic floor therapist to say eat more fiber, drink more water, or do this, but there's so much more to it than that. There's insoluble versus soluble fiber. What medications are you taking, how your body reabsorbs certain things, and your whole like kind of gut motility. So we actually just contracted with a nutritionist that sees patients virtually or in office in my practice twice a month. And a consultation is legit an hour. So, she sits through with you and says, what are your symptoms? What is your medical history? What does your diet look like? What are your medications? What are your goals? And then, we can kind of parse out like, hey, you know, you got diarrhea, you're drinking a bunch of water, and you're eating a whole bunch of fruits and vegetables that have high water content. So you're just adding more and more water, and you're actually kind of one of those people that we need to maybe kind of step back a little bit. And so that's how that's going to get figured out, not in an office visit with me, because I'm again looking for structural things that I can repair. Um, so we got a few minutes left, and before we jump to any other questions that Sonia may have, again, it's Pride Month. We have a special edition tonight, and I want you to touch on a little bit about, we talk about gender affirming care, but let's talk about how gender identity may play a role in how we treat patients. And so when we're talking about trans patients or patients who may identify with the opposite sex in which they were born, how does that impact care? And the reason I say that, because we see this even in the colorectal space outside of pelvic floor, a transgender patient, the chromosomes are still there. And so certain disease processes, a trans woman may still have a prostate and thereby is still at risk for prostate cancer or so all of those things, ovarian cancer and um, how does that play a role in how you care for patients and how you can appropriately address their pelvic floor, knowing that the basic anatomy down there may be different, even though they may not specifically identify with that anatomy?
This kind of goes back to the conversation we were having about trauma informed care. Just like you, it's in our practice. it's in our bylaws as PTs, like do no harm. And it's in my intake form. I ask about pronouns. I ask how they refer to their genitalia. What do you call down there? Some people don't. If they have a penis, they might not call it a penis. They might call it something else, or if they have a vagina they might call it something different than that. And so I usually ask, like, I'm as what I do, my career, I'm going to talk about the anatomy and what I see in front of me, but I also don't want to offend anybody. And so what do you refer to things down here? And it's not that I like, it's rare that I ever need to do any kind of work on the actual genitalia. And so unless it's uh, um, trans woman who's gone through a vaginoplasty, or a trans man who may have had some sort of penile prosthetic put on, there really isn't a whole lot of need for me to really engage with the genitalia unless I'm doing internal work. And if they have a vaginal canal, and the reason that they're seeing me is for, post vaginoplasty, they're working on dilation. Sometimes I will go into the internal, into the vaginal canal, the neo vagina. Um, but in terms of gender identity, I, being a queer person and being sensitive to just my queer identity and other people's queer identities, I really, I don't, I don't take that privilege lightly. Whenever people, again, I don't take insurance. I try to promote myself and market myself as a queer friendly healthcare clinician. And so if somebody's coming into my office, like, that is a privilege to me that they've chosen me to help them with their care, and I don't take that lightly. And so I really try, at the end of the day, I try to exude respect and treat them obviously with dignity and empathy, and approach them how they want to be approached. And at the end of the day, what they have, it does affect my job, but it also doesn't really affect my job. Like, I still can get to the pelvic floor in a number of different ways, and it doesn't really matter.
Yeah.
And so that's kind of how I approach it.
Awesome. Well, thank you. Before we take the final questions and close out, I want you to, for anybody who just kind of tuned in, you know, tell us who you are, tell us where your practice is, and if anyone is interested in seeing you, how they can find you.
Yeah. So my name is Lance Frank, pelvic PT. I have a practice here in Midtown Atlanta, Flex Physical Therapy. If people want to see me, they can either go to my website, flexptatl.com. They can find my Instagram, same name, flexptatl flexptatl, or my social media kind of persona with pelvic floor stuff is called Lance in Your Pants, and they can just shoot me a message there. All my like links for my website, my clinic, they're all linked there as well. Um, so yeah.
Awesome. Awesome. So, everybody, we're going to wrap up shortly, but Sonia, are there any more questions that are in the chat?
Yeah, so Dr. Lance, you actually kind of answered the last one that was coming to you, but kind of a similar one to that. It says, Dr. Lance, do you have a go-to approach to get patients to talk openly without shame? Um,
Um, I'd like to think that I'm approachable and I'm a friendly, likable person. And so I try to lead all of my conversations with just being a human and obviously asking the questions that I need to ask. But I usually, you can tell, and I'm sure, Doctor, you can obviously probably appreciate this as well. Like, people will come in and they'll kind of sit in the chair, they'll kind of be like recoiled, they'll kind of be like a little distant. They might not make eye contact when they're talking about their history. And I usually, like, you can pick up on that energy. Like, they don't want to be there. Most patients don't want to be in my office. Like, they would rather be anywhere else than
Same.
having to go through what they're going through. And so I try to, when they're talking about their history, if I'm getting that vibe from them, a common statement that I'll make is, I want to stop you right there. Like, I can understand the feelings that you're feeling right now. this is my job. This is my career. I've gone to school for a very long time to be able to do this job. So nothing that you're going to say in this room is going to shock me or embarrass me or make me feel uncomfortable. So I can understand that you might be feeling that, but I really hope that you understand that this is a safe space and nothing that you're going to share with me is going to shock me or be something that I haven't heard before. And then usually after I say that, they're like, wait, really? I had just this morning, I had a new patient and he was like, how many patients do you see a week? How many people do you treat with this type of issue? And I was like, I literally do this 5 days a week, all year long. I've done it
All
for
day.
almost 10 years. Like, this is
Right.
not something that is new to me.
Right.
And so I wish by being honest and like being vulnerable on my part and sharing that, this is a safe space, that I'm not gonna, run out of the room by anything that you're gonna tell me, usually puts a lot of people that are feeling any sort of shame or embarrassment, usually sets that at ease.
Yeah. And like for me, same with me, they're like, "Oh, I'm sorry back there. I tried to clean up." I'm like, "It's the butt." I'm like, but I'm
Yeah.
like, oh, they're like, "I can't leave." I'm just like, listen, I'm like, "You see all those people in the waiting room? I see all those butts out there, like literally all of them. Okay.
Yeah.
So it's okay. Like you trust
Yeah.
me, you're not going to get the prize today. Okay. So
Yep. Yeah. Yeah. It's
any
always
other,
it's it's always funny to me when patients, I always get a little giggle when they're like, I tried to like tidy up down there. I'm like, you didn't have to do that.
like, yeah,
You
what does
did
that
you,
mean?
you didn't have to trim anything. You didn't have to shave anything. Like, you don't have to do that.
Right.
Well, speaking
One
of
day I'm gonna
tidying
find one day I'm gonna find an air freshener in there, and I'm like, guys. So yeah.
Unnecessary. Unnecessary.
I was going to say the last question I had, speaking of butts, I'm going to read it exactly as it says. It says, wait, go back to this Tushy Touch Up. How do I get that?
Oh,
So,
call me. But no, seriously. So yeah, so tissue touch up is a way that we can restore your anal rectal functional and cosmetic and aesthetic and just kind of overall comfort health. So this is the Love Below series. I'm Dr. King-Mullins, also known as Dr. Tushy Touch Up. So excited to speak with Lance in your pants this evening, pelvic floor therapist extraordinaire in Midtown. So if you guys need my services, if you are curious about Tushy Touch Up or colorectal cancer screening or anal cancer screening or nutrition, because we now have a nutritionist that works with us. So colowellness.com or tushytouchup.com. There's patient forms on there. You can discreetly just request an appointment if you want to do virtual visits as well. So you can do it from the comfort and safety and privacy of your own home. All right. Well, with that, thanks y'all so much for joining us on this episode of the Love Below series. And the video from this should be posted before the end of the week, I think, to the YouTube channel. So if you missed anything and you need to click and rewind, just look for it. Bye. Thanks, Lance. Have a good
Yep.
night.
Bye. Thanks for having me.
Thanks.